Yeah.
Yeah, let everybody in.
We are live.
Good evening, everybody, and welcome back to AOMSI web series. We have Professor Jatin Shah with us today, and we start the session live now. Praveen,
Yes.
go ahead, play the music. Good evening, everybody.
Hello, everyone. Hello, everyone. Good evening and welcome again for a fantastic session on oral cancer and head and neck oncology. It's a pleasure to introduce the co-hosts who are going to help us with the session today. We have two co-hosts for YouTube, Dr. Sagar Vyshampayan from Mumbai. Hi, Shah. You want to say hello? Yes. And the Tata Memorial advert has Sagar on the screen, so we have a poster boy here to help us. So, and then we have Dr. Akhilesh Kumar Singh. Akhilesh, do you want to say hi?
Hi, sir.
We have Akhilesh is from Banaras. And then we have two co-hosts to help us on the Zoom platform. We have Dr. Satyajit Dandagi. Satyajit, you want to say hi? Satyajit.
Good evening.
And Amit Dhawan.
Hi, Kanan. Good evening.
Good evening. And Amit, do you want to introduce Dr. Pankaj?
Yeah. Yes. Thank you, Kanan, and good evening, everyone. So it's a pleasure to introduce moderator Professor Pankaj Chaturvedi again in this tumor board discussion. So PC sir is a head and neck surgeon, we all know, and at present he is a deputy director of Tata Memorial Hospital and a Secretary General of International Federation of Head and Neck Oncologic Societies. So we welcome you, sir. Over to you, and please take over. Thank you.
So thank you so much, Amit, Pramod, Preetham. This is indeed a great opportunity for us to get the depression of COVID and Corona epidemic out of our mind, so that we are able to get back to at least gathering knowledge, understanding things, and of course, this crisis is going to be over very soon. So this was Dr. Jatin Shah's idea that the hunger for knowledge is eternal. These crises will come and go, but we all have to keep abreast with the knowledge. And with this theme, when I approached Amit, then he was very enthusiastic, and Preetham and Pramod, everyone, that yes, there is a huge audience which is ready to listen to Dr. Jatin Shah and Dr. Sandro Porceddu. And I take this opportunity to thank AOMSI for allowing this opportunity. And I have with me, apart from the co-hosts who have already been introduced, I have Dr. Jatin Shah, and I don't think Dr. Jatin Shah needs to be introduced, because if I introduce, whole 90 minutes might go in that. So Dr. Jatin Shah is the professor at the Wheel Medical College and of Cornell University, and he holds the Elliott Strong Chair, and he is the CEO of the International Federation of Head and Neck Oncologic Societies. And I would say that some of you should guess his age. And if you make a right judgment on his age, then perhaps he will beat all of us hollow, because the energy that he has is unimaginable. And I truly consider that he's a role model for many of us. So thank you, Dr. Jatin Shah, for joining us. And everybody is really excited to listen to you. And then I have a very dear friend, Sandro Porceddu, and he is a very good, brilliant radiation oncologist and a very dear friend for all of us. And he is at the Brisbane's Peter Alexandria Hospital, and is a professor at the University of Queensland. And it's a pleasure, Sandro, that you are with us. and your insight, knowledge, and experience is really going to benefit the participants in India. And for your knowledge, this is being seen all over the world. So it is not that we are restricting to India, but the link has gone all over the world, and we are being watched even in South Africa and many parts of the South Asia. And we also have Dr. Srinivas, who is the oral and maxillofacial surgeon, and he is a very, very reputed oral maxillofacial surgeon, and who has interest in skull base also. And he works in the division of oral maxillofacial surgery at Omaha, Nebraska. It's a real pleasure, Srini, to work with you. And also, we are eager to listen to your views. And certainly, this is going to be a very beneficial session in the next 90 minutes. Srini, Dr. Shah, Sandro, and Srini, want you to speak for some time? Then I start, or should we go straight to the panel discussion?
Pankaj, in the interest of time, we should proceed with the cases.
Perfect. So I'm going to share the screen with you. Perfect. Can everyone see the screen?
Yes, sir. Good to go, sir.
Perfect. So Dr. Shah and Sandro and Srini, this is a very common problem that we face in India, and Arjun is going to present this case.
So we had a 47-year-old male who had come to our OPD at Tata Memorial Hospital. He came with a complaint of a small white patch, 1 by 1.5 centimeters on the left buccal mucosa. He had a history of chronic tobacco usage, especially smokeless tobacco, gutka more specifically, which he chewed for the past 10 years. This white patch used to is waxing and waning and increases and reduces on size. It is heterogeneous in nature, and his chief complaint is burning sensation in the left buccal mucosa, which radiates towards the entire oral commissure.
So, Dr. Shah, let me first ask you that this is a very common problem, and I'm sure having the Indian roots, you realize that this is a very prevalent problem also. So my first question is that, how do you counsel these patients when you see them, because they're all worried about the malignant transformation?
So I think, counseling is one part of your assessment, but more important is whether what you are seeing is a unifocal lesion or this is a diffuse process throughout the oral cavity where the presenting lesion may be the prominent one, but you see similar changes in the contralateral buccal mucosa along the occlusal line of the ipsilateral mucosa, some changes on the junction of the hard and soft palate. And if you have such diffuse changes, then the need to pursue further depends on what is your index of suspicion for conversion to malignancy from a straightforward dysplastic or leukoplakic lesion. And that is manifested by either a speckled leukoplakia, erythroplakia, or lesions which are exophytic, cauliflower-like, proliferative leukoplakia. And those are the lesions which you need to worry about from the point of view of doing a biopsy or even treating it surgically or otherwise.
So Srinivas, let me pick your brain. Now, Dr. Shah said that we should do biopsy, and we should do the biopsy based on the index of suspicion. What is your take? Should we do the biopsy in the first sitting? Should we counsel the patient, ask them to come for biopsy? And if at all we have to do biopsy, I know a lot of people in India, they do this brush cytology. Then there is something called exfoliated cytology, brush biopsy, incisional biopsy, excisional biopsy. So would you like to guide the participants about how to take a biopsy? Srinivas, can you hear us?
You hear me?
Yeah, we can hear you.
Yeah. So these cases, more than the T4s, are the ones which give most of us some sleepless nights. So any type of biopsy which you want to do is to see a dysplastic to a malignancy as a spectrum. Excuse me. So in this spectrum, which you are trying to analyze, sorry, I've been waiting here for a long time, I guess. So what I would emphasize is these are known as mapping biopsies. I would not completely concentrate on one particular area. I would rather do an entire field change. I mean, the concept of field cancerization is where this is evident here. So different parts of this lesion could have different stages of dysplasia, from the mild to moderate to severe, or a frank malignancy here. So I agree with you regarding the brush biopsy, which you could do just by a cotton tip applicator, putting under the microscope with some amount of alcohol spray, which are available fairly in the open market. It's available fairly easily. So what I would emphasize as a key terminology here is mapping biopsies, not one particular biopsy.
So Srinivas, my personal experience is that these patients, usually when you try to do brush or when you try to do exfoliated cytology, usually you get only dead keratinocytes, and that leads to false negative. And if you ask a pathology friend for any good dysplasia diagnosis or grading of dysplasia, they need significant amount of tissue, including the full depth, including the stroma and the basement membrane. Dr. Shah, what would you like to say about the type of
No,
truly...
I absolutely agree with you. All of these lesions are in the spectrum from slight atypia to invasive carcinoma. In between, you have mild dysplasia, severe dysplasia, in situ carcinoma, and invasive carcinoma. So it's a continuum of changes. Where the entire superficial layer is keratinocytes, which are going to look normal. If you do surface examination with a telescope, like a contact endoscopy, or look at the surface of the lesion, they are all going to be mature, many times dead keratinocytes and a layer of normal keratin. So I particularly do not put any value to spend the money and effort on brush biopsy, because that is going to be negative. Brush biopsies are helpful where you have an obvious proliferative exophatic clinically diagnosable cancer. But where you have areas of white dysplastic lesions, I think what you need is the basement membrane, i.e. the zone of invasion between the keratin layer and the submucosa. So if you're looking for tissue diagnosis, I would say do an incisional biopsy from the most suspicious looking area.
So Dr. Shah, while we're discussing about the biopsy, I completely agree with Srini that yes, there will be heterogeneity. Some areas will have dysplasia, some area will not have dysplasia. So Dr. Shah, in the same breath, if I say that the dysplasia, if the histopathology report is mild to moderate dysplasia, and this is the kind of the lesion, and what would be the next step? The patient does have dysplasia, patient is symptomatic, he is very worried, medical treatment or surgical treatment or nothing?
So remember what I said at the outset, is this a diffuse process throughout the entire oral cavity, or is this a focal local process? If it is a unifocal local process, then surgical excision would be diagnostic and therapeutic. Conversely, if you got diffuse areas throughout the oral cavity, where the changes range from atypia to dysplasia, and there is no frank invasive carcinoma, either you can, if the patient is asymptomatic, keep him under surveillance. I am not convinced that any of the non-surgical treatments have shown any lasting benefit. We have gone through use of antioxidants, we have gone through the use of cis-retinoic acid, And all of these agents cause temporary regression, but the moment you stop the treatment, the lesions come back.
So, Srini, we have the recent Cochrane review on secondary prevention, that is chemo prevention of the leukoplakias. And that also says that though we have lots of researches going on, as Dr. Shah said, but there is no one drug that we can recommend for preventing malignant transformation in this leukoplakia. So what is your view on this?
This is a loaded question. Yeah. So between, as you said, the recent study which you're referring to is the 2016, a Cochrane review, I guess, of Lodi. Lodi was the first and Saman Varnakulasuriya was the second author on that. So this Cochrane review reviewed every bit of past 20 to 30 years from 1990s to currently, what we have been using as medical treatment. So just by the knowledge, for the first 10 years, there were like 30,000 papers, I believe. And then between 1990 to 2000, there were 30,000. Then 2000 to 2010, there were about 90,000 papers talking about this vitamin, steroids, and other things. And then there were 150 to 170,000 papers on different modalities of medical treatment. So when you have so much of noise, the signal is very poor. That's my take on it. So as Dr. Shah rightly said, none of this have gone to show any promising feature of completely eradicating it. Another key thing here is not only removing this leukoplakic patch or a dysplastic patch, preventing recurrence or further spread of it would be the ultimate aim of successful treatment. So when you cannot achieve that, I think it fails all these medical problems. One last point would be, when you review all the papers in that Cochrane review, couple of them, I think Shankar Narayanan from Kerala or Singh from New Delhi or other people who have reviewed all this, they cannot agree with one particular dosage of, say, beta carotene or I think lycopene from New Delhi, I guess. So there were different dosages. So there is a little heterogeneity again in the dosage of the medical treatment. There is differences in particular way of looking at what were the dysplastic changes. So Shankar Narayanan, Singh, and other people are the ones which you can see this on the Cochrane.
Yeah. So Srini, Dr. Shah, I completely agree, and that was a good summarization. Sandro, would you like to say something? What is the way you are dealing with such lesions in Australia?
So firstly, to echo what's already been said, our pathologists really dislike sort of brush biopsies, because if they can't see the basement membrane, they provide you with a very ambivalent report. So we tend to biopsy the areas of greatest suspicion. As you know, these are long-term patients that need follow-up. Our management, we were involved in a vitamin A retinoic acid trial. It was underpowered, didn't show a benefit. We don't use any medical therapy. We simply observe them, encourage lifestyle changes, fix up their teeth, try to get them to stop smoking. And for the very symptomatic lesions, we will laser them.
Perfect. Dr. Shah, one last, very quickly, if you can say that there are lots of options for surgical excision, cautery knife, cryo, laser. If you have to give one word message, what would be that?
I don't think it truly matters as long as you don't char and burn the tissue. If you use an electrocautery, be careful not to char the tissue to ruin the specimen for the pathologist to interview. So use a cutting current, and you can use it cautiously. It's a superficial excision if you are excising only leukoplakia. If you want to use a scalpel, it's fine. If you want to use a laser, you need to decide you are using the laser as a cutting instrument or an instrument to evaporate the condemned mucosa. So you need to make that decision. If you use the latter, you will not have any specimen. You'll have destroyed the lesion in situ, and that may be appropriate for very superficial diffuse lesions where excision could be more morbid than just destruction of the mucosa. So I think the choice of treatment depends on the lesion, your familiarity with the instrument, and what is the goal of your intervention. Is it a biopsy? Is it treatment? Is it prevention of conversion? And whether it is focal or diffuse areas.
Perfect. And to just complete the list, photodynamic therapy is still an experimental treatment. We can't offer it on a routine basis. Am I right, Srini?
Yeah. Our experience from, at least my learning experience of photodynamic therapy, which has been there again from 1990s to currently, was from London, where the guys in King's College, they used to frequently do this for their oral lesions. And only thing which is developed in the photodynamic therapy recently is, even in other dermatological conditions, the third generation antibody specific excitement, where the laser excites the antibody to the specific cell, has come out. So that's the third generation of it. So, we're seeing a gradual change or progress in that too.
Perfect. So we move on to the next presentation, and Burhan will present the next case. Any questions from the Zoom or Google? Yeah, there's YouTube. Amit, Satyajit?
Yes, sir. One question, are there any guidelines for identifying the biopsy site in a large lesion?
So let me take the privilege of answering it. So you should look for the most suspicious area. And the most suspicious area is the indurated area, bleeding area, painful area. So if you, and speckled area. So I think that is the site where you should direct your biopsy. Any other, one question I have, and I'll throw it to the panelists. Dr. Shah, there is a question that should we do molecular testing?
If you have the money and the facility, knowing that that will not help you in any clinical decisions, I would say go ahead and do it in a research setting. But in a therapeutic setting in the community, it has no value at this point.
Perfect. So Burhan will present the next case. Burhan.
Burhan is not audible, I think, sir.
Okay, so Burhan is not audible. I think he has not put his audio. So Arjun will present this.
Okay, so this was a young female that presented to our OPD who was recently married, and she was severely symptomatic in the sense that she couldn't open her mouth too wide. This mouth opening had progressively reduced over the past 2 years. On further taking her history, she had a history of areca nut chewing for the past 6 years. There were no other lesions identified in the oral cavity other than thick bands which were palpable on the bilateral buccal mucosa extending towards the retromolar trigone, and a shortened uvula which was present.
So Dr. Shah, this is a very common problem in your native state of Gujarat. And I'm sure you are the one who knows, you must have seen it in India, but I don't know how often you see it in US. So my first question is that, why do you think that this is less common in US, but more common in India?
Pankaj, you are asking a $64 question. I left Gujarat over 55 years ago. So, we don't see the trismus as a result of submucous fibrosis in the United States, in the white population, or even in the colored population. So this is not a disease that we frequently encounter. And the patients I do see in the United States are particularly those of Asian origin, Indian, Sri Lankan, Pakistan, Bangladesh origin, who have come to live in the United States, but bring the habits of chewing tobacco, pan, etc., bitter nuts with them. But I am, you folks have much more expertise than I do. And I'm told that people who even do not use the chewing habit of tobacco or bitter nuts or anything, they also have submucous fibrosis. So is it due to nutritional factors? I'm not aware of personally, but I yield to Srinivas and you because you are the experts in this field.
So Srinivas, this lady is symptomatic. She's young, recently married, and she has you can see that the mouth opening is reduced and it's progressive. So how would you approach the management of this lesion?
Pankaj, thanks. As Dr. Shah said, this is a condition which, other than the Eastern population, I've occasionally seen when I was practicing in the West Coast, from the Asianic population from Guam and Pacific Islanders. They also presented with this. So having lost a couple of patients with the best treatment, I would take my time to examine because trismus direct examination may not be comprehensive. So I could use flexible endoscopy, adjuncts to even imaging like MRI and other things. But that is when the spectrum is suspicion towards malignancy. But doing endoscopy or repeated multiple palpable examination is the key to a treatment plan, is my emphasis.
Perfect. So just to summarize that we can go on and discuss this case for several hours, but the end, if you ask me what is the treatment, I would say there is no medical treatment. There is no surgical treatment, and surgical treatment is reserved only when there is less than 1 centimeter or 1.5 centimeter mouth opening. And whatever surgery you might do, whether it is bilateral coronoidectomy, whether it is band release, the results are not so encouraging. It is encouraging in few centers and with few doctors, but overall the results are very limited. And if you go on some publication, there are 32 types of treatment which are recommended. And as Srini said, that if you have too many treatments available, that means there is no good treatment for this. Similarly, observation is very difficult because these people have a lot of burning sensation, but we have to do the lifestyle modification for them. Hardly any medicine available for them. So we move on to the next case, and maybe on submucous fibrosis, we can have another session. So we move on to the case number 3. Burhan, are you ready? Can you present this? Okay, Arjun, you can present this.
So this is a 26-year-old male, a female who had come to our OPD. Her chief complaint was a radiating pain on her right lateral border of the tongue, which was radiating to the back of her throat. She was having no frank difficulty in swallowing. On examination, we found a 3 into 3 centimeter right ulcer over the right lateral border of tongue, which was about 1 centimeter away from the tip of the tongue. It was quite far away from the posterior part of the tongue, base of the tongue. It wasn't crossing the midline, and the floor of the mouth was free.
So, Dr. Shah, a lot of these youngsters, they keep coming to us and asking one particular question, that how do we ascertain the thickness of a lesion in pre-operative setting while doing the examination? Because now thickness is an important predictor which tells you whether T2 or T3 will depend on that.
So I think, what you are referring to, Pankaj, is how do you stratify the tumor between a T1 less than 5 millimeters, T2 5 to 10 millimeters, etc.
Yes, sir.
The millimeter markings are simply milestones. There is nothing magic about 4.9 millimeter and 5.1 millimeter separating the two. It's a continuum. And your fingers can easily tell you this is a superficial lesion, this is a deep lesion or this is a very deep lesion. I don't think any even younger, inexperienced clinician will have difficulty assessing a 1 millimeter thick lesion and a 10 millimeter thick lesion.
Perfect.
So the clinical assessment between thin, thick, and very thick is enough to call it between T1, T2, and T3. If you have the luxury of imaging and the expense of imaging, then do an MRI and not a CT scan. That will give you better assessment of the third dimension of the tumor.
So Sandro, if this person would have come to your clinic after the clinical examination, as Dr. Shah said, would you do an imaging? And if you do an imaging, what imaging you would do?
So we would do an MRI to assist us in determining the clinical stage of the patient in terms of both the tumor dimensions and the thickness. If we're doing an MRI, we will also image the neck to look for lymphadenopathy using the MRI. And we generally do a staging CT scan. We don't necessarily do a PET CT in everybody routinely. So MRI and CT and discuss in our tumor board meeting.
So Srinivas, so for this lesion, what imaging protocol that you follow in your hospital?
As Sandro said, MRI. And one key thing for our younger audience, which I would emphasize, is when there is close to the floor of the mouth or a ventral tongue, you could separate this by placing a small gauze or something so that the tongue is elevated off the floor of the mouth, and you can get a better imaging characteristic. And it's been, you can assess it even by imaging correlating with your clinical exam.
So Dr. Shah, here is, because if all the panelists and moderators agree on every point, then people will think that it's a fixed discussion. So I raise a very provocative question. This person, if the person requires surgery, which is wide excision with a neck dissection, do you agree with that, that this person certainly would require a neck dissection since it is a T2 lesion? And if so, what is the role of imaging in this person?
Very good question, Pankaj. And you're absolutely right. If you look at the clinical characteristics of the lesion, can you go back?
Yeah.
It's not only a T2 by measuring criteria, but if I look at it, this is an angry looking advanced tongue cancer. It is probably as deep as it is seen on the surface. That entire pinkish area you see from about 1 centimeter from the tip all the way to the commissure of the mouth posteriorly, that's all submucosal tumor extension of the from the cancer. So this is an aggressive cancer, although it may be stage T2, but it's a deeply infiltrating lesion. The risk of nodal metastasis in this patient, if the neck is clinically negative, is as high as 40 to 45%. And if the neck is negative, the least she would need would be a comprehensive level 1 to 4 dissection on the ipsilateral side.
Perfect. So this person would certainly require, because this lady is T2N1M0, so of course neck dissection is required. So I'm just wondering that imaging, if the treatment plan is already decided and the surgeon goes by digital palpation and goes away from the tumor based on the digital palpation.
Yeah, Pankaj, I'm sorry I did not answer your first question completely. Yeah. Even though you have made the decision about the need and extent of neck dissection, you do need imaging of the neck, a contrast-enhanced CT scan, if you have the facility and if your patient has the financial ability to do so, because occasionally you may be unpleasantly surprised with a contralateral neck node, a low-level neck node, or a node in the posterior triangle of the neck, in which case you would have to modify the extent of neck dissection.
Wonderful. So I think if we have a good radiologist, this information can be achieved even on the MRI, which has been already done to image and stage the primary. Do you agree with that?
Yeah, that's fine. I think, in general, for assessment of the neck nodes, a contrast enhanced CT scan is better than MRI. MRI is better for assessment of the primary tumor. CT is better for assessment of the neck nodes. But if you have to do only one, and if you are uncertain about the depth of invasion, then I would say do the MRI.
Perfect. So Sandro, this lady is a Bollywood celebrity and she doesn't want surgery and she is coming to you for an alternative.
He would be worse.
Yeah, so I guess, Pankaj, what you're trying to do here is create a little bit of discussion and some degree of controversy, if we can add that to the case.
So that people awake.
So look, the fact that she's a Bollywood actor in some respects actually creates a stronger case for surgery, because if I were to treat her with radical radiotherapy, I'd probably have to add chemotherapy. She would therefore then need 70 gray of radiation. Her risk of osteoradionecrosis, long-term complications go up. And at the end of the day, we don't obtain all the histological important features that we may get from the surgical procedure. So in this particular case, I would counsel her against chemoradiotherapy. I think a good, it's a well lateralized lesion. We haven't seen the imaging. It is going to be a thick tumor, but I would suspect a good resection. She was probably going to need some sort of reconstruction. I don't think primary closure will likely do the job here. And then the appropriate post-operative radiotherapy plus or minus chemotherapy, depending on the pathological features.
So, Sandro, what is the indication of brachytherapy in oral cancer? Do you practice these days?
So, I guess in my region, we've moved away from brachytherapy. Brachytherapy is a good technique, but it needs the institution to be appropriately set up. You need a dedicated oncologist and physicist who are committed to that, and you need a critical mass of cases to come through to justify it. With the advent of modern radiotherapy with intensity modulated radiation, and then the spin-offs such as VMAT and tomotherapy, which are highly conformal treatments, most of us have moved away from brachy, not because brachy is inferior, but basically because of all the logistics that you require to run a brachytherapy program.
Okay. So Srinivas, this Bollywood celebrity is very disappointed because Sandro has said that radiotherapy is not possible and surgery is the best treatment. And now she has gone to you and she is saying about what would be the margins that you will take, how big will be the surgery, and what will be the reconstruction that you will do.
We all know the textbook answer, 1 centimeter margin around. So we would want to discuss the volumetric margin based on your imaging finding plus your clinical examination. As Dr. Shah clearly said, there's a lot of inflammation, there's a lot of edema around the region. So it is a volumetric, a depth, on all the 4 dimensions or the 3 dimensions of it, you need to get a margin of about 1 centimeter would be my answer.
So Dr. Shah, so margin is settled. Now, what is your algorithm for reconstruction? When do you do reconstruction? When you do primary closure? And if you do a reconstruction, what kind of reconstruction you will do?
So Pankaj, the fundamental principle of oral cancer surgery is retention or restoration of function. Making the tongue look good by putting in a flap does not necessarily improve function. In fact, sometimes overutilized flaps are detrimental to good tongue function. So the surgeon needs to decide the remaining tongue after resection is going to be adequate enough for clarity of speech and for swallowing or not. And that judgment will improve with experience, obviously. But in general, if you have to remove the entire anterior 2/3 of one side of the tongue, the probability that you will need a flap is high because the remnant tongue will be a thin snake-like tongue, and it will be not in full functional capacity because it will get tethered down to the floor of the mouth and will hamper with mastication. And in that setting, you will need reconstruction. And if you have the facilities and the team to support it, the ideal method of reconstruction for this would be a radial forearm free flap. It doesn't have to be a very big flap. My suggestion to the reconstructive surgeons is who are attuned to sticking in a large volume of tissue in the mouth, which is actually detrimental to the function. So what I tell them is look at the specimen and make your flap about 1 centimeter bigger than the specimen. And that's the size of the flap you need to restore the contour of the tongue such that the remaining tongue will have enough mobility to provide the function necessary.
Wonderful. So Srinivas, this lady, as we discussed, is very worried about the scar in the neck, and she's arguing and she's maybe bargaining whether we can do a sentinel node biopsy, what kind of neck node management. So what will be the strategy that you will adopt?
Great question, Pankaj. So sentinel node biopsy is a possibility. Certainly, if there were no frank palpable nodes when you palpated the neck or when you imaged the neck, as a single answer. And for a size of T2 and 1, which you're already telling me, I would go ahead and do a neck dissection in my hands. In an American experience, as Dr. Shah would agree, that would be her maybe one modality treatment. In oral cancer management, the emphasis is on a single modality success of therapy would be the best thing to go for. And that would be my take on that.
So I completely agree that we would do a neck node management, and that is mainly the supraomohyoid neck dissection, and level 1 to level 3. Dr. Shah, would you like to comment on the levels of neck node removed in an end?
Yeah, I think this is a lateral tongue lesion.
Yep.
And I draw your attention to an old paper that came out of Johns Hopkins in the early 90s by Joe Brennan, which showed that for lateral tongue lesions, the incidence of lymph node metastasis at level 4 was 15%. This is a large lateral tongue lesion, and adding level 4 takes probably additional 5 to 7 minutes to a standard supraomohyoid neck dissection. So I would clearly do level 1 to 4 dissection. The other thing you mentioned about the worry in the mind of the Bollywood star about the scar of neck dissection. And I think we need to pay more attention there rather than doing something unconventional. If you limit your incision to a single transverse incision along a natural skin crease, not going up towards the mastoid process and not coming up towards the chin, single transverse incision along a neck skin crease in the neck, this scar is not visible. I have challenged my fellows numerous times in my clinic when the patient is sitting across from me and the fellows are behind me. I ask them, tell me which side was the neck dissection, and they can't tell me. Now, either the fellows were dumb or the patient had a good scar. So I think if you pay little attention to placement of the incision, keeping it to a single transverse incision, no curves going up or down, I think it's a invisible scar. You can do your job done well. This lesion comes up to the tip of the tongue. So I would include level 1A, 1A, 1B, 2, 3, 4. About 2B, I would make a decision only if I encounter gross nodes at level 2A.
Perfect. I completely agree, because that is how we preserve the injury to the spinal accessory nerve. Sandro, this question is for you. This Bollywood celebrity heard about something happened in US where HPV was positive, and that led to a lot of news coverage. And she wants to know whether this is HPV positive or not. So this is a tongue cancer, and we want to know what is your protocol for HPV testing in these people?
We don't routinely do HPV testing for oral cavity cancer. So we don't look for P16 status. It will be present in some cases, but the point is that in oral cavity cancers, the presence of HPV has not shown any significance. It's really only for oropharyngeal cancer. So we don't test it routinely. Some people test it, but that's purely because for no real strong scientific merit. Pankaj, can I just make a point about, from a radiation oncologist perspective, about the scar that Jatin, that Professor Shah mentioned? We as radiation oncologists love it when the scar can be left unilaterally. If you come across the midline, the radiation oncologist will chase that scar as part of the surgical bed. And that, for our Bollywood celebrity, would increase the lymphedema and brings in the larynx into the radiation volumes. So while I'm not suggesting people should compromise on access from a surgical perspective, they should keep in mind that if they cross the midline, then the radiation oncologist will cross the midline, and that will increase the morbidity of the treatment to the patient.
I completely agree. Not only the scar, but even the drain placement. And the drain site placement also you have to chase, because that is one area we have to be very careful that it should not be very difficult area for your coverage.
Pankaj, just to add one more point to your bullet point there about sentinel node biopsy, one of the exclusion criteria of the, if I remember from, I think the CENT trial, was that a clinically obvious lymph node, which could be positive, was an exclusion criteria.
Correct.
So,
correct, absolutely correct. So we move on to the next case. And
sir, Pankaj sir, so there is a question from the audience in continuation with that case. What would you prefer in this case of tongue lesion, a compartmental resection or a wide excision?
So Dr. Shah, this is a very traditional question. Would you do?
And I also see a question on the chat room. Can this be done with TORS? So let's answer all three questions.
Okay, so Dr. Shah.
Thank you, sir.
I'll be very brief.
Yeah, please go ahead.
Yeah. My short answer is this should be undergoing an adequate resection. An adequate resection means taking, like Dr. Srinivas said, 1 centimeter margin in all dimensions. The concept of compartmental resection originated in Milan by Cesare Piazza and his colleagues, they would have gone on to resect the entire right hemiglossectomy, the old terminology. Cancer does not follow anatomy, and therefore there is no benefit or virtue of doing a compartmental anatomic resection of the entire muscle involved by the tumor. So I don't think I subscribe to that. No. And finally, if you have the money, the time, and the energy to invest in doing a simple thing the hard way than do it by tours.
Okay, that was a good one. Sandro, there is a question in the chat box that this celebrity is looking for something which is appearing in the newspaper these days, that is proton therapy.
Yeah, you can't discuss any case without bringing up the proton therapy question. I think the first thing to say is that access to proton therapy is quite challenging, and so it's not readily available to everybody, and it's still a very expensive option. The second thing is that there's nothing biologically different about proton therapy and photon therapy. The difference is that the proton therapy will give you slightly better conformality in the oral cavity. So the mucositis will be a little less, but the cure rate will be exactly the same. Again, it may also lessen the risk of osteoradionecrosis. But what you're doing is you're using a very expensive piece of equipment to really deal with something that can be easily managed, well, you know, relatively easily managed with a very nice operation and post-operative radiotherapy.
Perfect. So we move on to the next case, and Burhan will present the next case. Come, Burhan. Sit here. Yeah.
So this is the 35-year-old male, and he presents with a lesion, ulcero-infiltrative lesion in the right lower gingival.
Can you all hear him?
Yeah.
Okay.
So this 35-year-old gentleman, he presents with an ulcero-infiltrative lesion in the right lower gingivobuccal sulcus. It abuts the sulcus, and if you see externally, there is skin induration present at the region of the lower lip and the commission of the oral cavity. His biopsy is proven for squamous cell carcinoma, and the imaging shows that there is no bone erosion, but however there is a enhancement seen in the right buccal mucosa, and the thickening is seen with paramandibular thickening of around 1.5 centimeter on the height of the mandible. There is no bone erosion, and it shows right level 1B node, which is 2 by 2 centimeter, and suspicious for metastatic node.
So Sandro, I would like to throw this to you first, that this patient is waiting for an alternative to surgery. Again, I'm sorry to keep bringing this issue. He feels that surgery he doesn't want.
So could we, I guess, to make the clinical call, if he's not seeking surgery, let's go down that route of radiotherapy. Or what I really need is I need some more information from an imaging perspective. I would get an MRI to give me better delineation of the soft tissues. I would like a CT with bone windows to just confirm that there's no bony erosion. Again, this is a very nasty looking lesion, and we would again counsel this patient toward an operation. Now, it's not big enough looking at it like that where I would give this induction chemotherapy. If I was to treat this patient, it would be along the lines of straight definitive chemoradiotherapy. Now, this is after we've discussed this extensively with the patient and he's still declining surgery.
So in your tumor board, you are very clear that you will counsel these patients that surgery is the best treatment, correct?
Correct. So just to qualify, in general, oral cavity tumors, our preferred option if we have a resectable tumor is surgery. If they're medically inoperable, surgically inoperable, different story. But for oral cavity malignancies that are surgically resectable, medically fit, that would be our preferred option.
So Srinivas, this patient is now again taking your opinion because it seems that radiotherapy is being denied because if surgery is possible, it should be done. That is what Sandro says. And the patient is worried about the extent of surgery. And how do you make a decision on the extent of surgery, knowing that the bone is not involved and you have a gingivobuccal sulcus lesion?
The neck is imaged, of course, and we know that there is a positive lymph node, Pankaj. And so it would still involve some amount of either a examination of the patient, whether he has paresthesia, if he has trismus, if he has any floor of the mouth involvement, which I don't see on the CT scan section, which I can see from here on the single image. So he would need a cutaneous gingivobuccal margin resection. And one additional thing is to do either a marginal mandibulectomy, strip the periosteum, would be my initial thought on the surgical planning.
So you would be doing the mucoperiosteal stripping?
Yeah.
Okay, and here if you see on the skin side, there is redness and there is a localized alopecia that shows that the skin is also not healthy. So certainly it can't be an intraoral excision. It has to be from outside.
It's a composite excision, if I should qualify my answer. So
Shah,
unfortunate, he will lose a bit of his lip too. Sorry.
So Dr. Shah, Sandro has clearly said that if the patient is suitable for surgery, he should undergo surgery. I have yet to find a patient who is not suitable for surgery, but he is suitable for CTRT. I'm just joking, Sandro.
I understand.
So Dr. Shah, what would be your treatment protocol in this lesion where you have a gingivobuccal sulcus lesion, bone is not involved, angry looking skin?
So I think, a brief comment about radiotherapy, and I completely agree with Sandro. If you were to go the route of non-surgical treatment, this patient will wind up having surgery under the worst circumstances. The patient will have exposed bone, exfoliated teeth, non-healing ulcer, and probably persistent tumor requiring salvage surgery. So non-surgical treatment is not the direction in which you want to go, and I totally agree with Sandro on that. Unfortunately, even though the bone does not seem to be involved, although we don't have bone windows on the CT scan, but let's assume that radiologically the bone is not involved, the lesion is sitting in a wrong place. It is sitting right on the mandible. I am not a subscriber of periosteal stripping, which is very popular in the maxillofacial world, popularized in the United Kingdom. Because what you have is you are getting a 1 centimeter margin all everywhere else and a sub-millimeter margin on the periosteum. That doesn't make sense to me. Besides, if you were to do a marginal mandibulectomy, the reconstruction of this patient is going to be much more difficult with a marginal mandibulectomy than a straightforward segmental mandibulectomy through and through resection, fibula free flap, and the skin island to cover the exterior. So I would do a segmental mandibulectomy to get adequate margins in all directions, through and through resection of the cheek, neck dissection, fibula free flap.
Perfect. So, Dr. Shah, what would be the indication for marginal mandibulectomy in oral cavity in your book?
So you're talking about the book or me?
Book.
Okay. So marginal mandibulectomy, like it says, is to secure margins around the tumor. It is not a marginal cancer operation. It is an operation to secure margins around the tumor. So the indications for marginal mandibulectomy are minimal inversion of the alveolar process, cortical erosion of the lingual cortex, and that's about it.
Perfect. So basically, it is not the height of the mandible, but point of abutment need not be disturbed, because if you disturb the point of abutment, you are disrupting and taking away the periosteum with a very close margin. And perhaps we know that there is nothing like the tumor does not always go from the occlusal surface. It can directly penetrate from the point of abutment into the cortex. And when you disrupt the point of abutment, you can leave behind disease. Is that what you are trying to say, Dr. Shah?
Yes, that is true. Although there is a very old study by McGregor in the 1970s, where he did whole organ section studies of mandibulectomy specimen to show that extension of tumor from the oral cavity, from the tongue or floor of mouth into the mandible does not occur through the intact cortex. The tumor ascends over the lingual gingiva into the sulcus, into the socket, and then into the mandible. However, that was so in non-radiated patients. Patients who had received previous radiation, you could see the tumor penetrating directly through lingual cortex. So I think it's a good observation that if the lingual cortex is intact, unlikely that the mandible is going to be involved from tongue or floor of mouth cancer. Nevertheless, that lingual cortex, if the tumor approaches that or is sitting on it, is condemned, because there is microscopic infiltration that you cannot prove by grossly looking at it.
Perfect. I completely agree. So we are very clear that this patient requires surgery, and considering the height of the mandible and point of abutment, the best option is a segmental mandibulectomy with microvascular reconstruction with free fibula. Sandro, would you agree with that?
Yes, I agree. It's important at the time of surgery. I mean, some of these teeth are going to go with the segmental anyway, but from a radiation oncologist's perspective, those teeth are not looking very healthy. They'll either need some restoration or removal at the time to reduce the risk of ORN down the track.
And Srinivas, the question is that if we are doing a fibula, then do you do the implants immediately, or you do secondary implants?
So yeah, we've done both. It can be done, and you need to think about the patient's post-operative course. So as you say, the question is loaded when you say, would you do the fibula implants immediately, is you work backwards in your planning for occlusal rehabilitation. As a reconstructive hat, I would start with looking at the patient's occlusion. So planning what the length of the resection margin is, and the number of teeth or the implants which need to be placed. And they can all be done at the same time with the minimal in-house planning.
So, Dr.
And
or second implant?
So you can come back and put implants after the radiation is done. So in a case where, just to add another angle to this discussion, to Sandro as well as Dr. Shah, if you think, then it is a segmental resection and it is a T4 lesion, which is involved the bone, then he would get a second therapy. That is possibly he may get radiation. So in that case, I mean, you may postpone. There are some people who say postpone the implants for a later date.
Correct. So that is what I was coming to. Dr. Shah,
I think, Srini rightfully pointed out, putting implants into the bone is not a technical feat. There is enough technology available, and it makes it pretty straightforward and simple to put the implants. But the issue is, what will the implants do for the patient? For example, if he has no opposing occlusal teeth, then the implants have no value. If it's only the last molar tooth, the implant probably has no value. So you need to decide the ultimate goal of putting implants. We have a relatively short but a pretty extensive experience since 2015 of nearly 80 patients who have had dental implants. The number of implants, I believe there are 170 or something like that. And they do hold postoperative radiation well, because I think that was a fear that the patient, the fibula may not handle post-op radiation if there are implants inside it. But we forget that when you do fibula free flap reconstruction, you already have metal screws and plates to fix the mandible, and that handles the radiation quite well. So adding implants does not necessarily or radiation is not contraindication to putting implants if they are appropriately indicated. And if they are, we would do it primarily.
Perfect. Sandro, any word of caution when we are giving adjuvant radiotherapy with implants? What is your preference?
Look, I think putting a nice healthy flap, from the implants point of view, it doesn't bother me whether they're there at the time of radiation or not. Pankaj, the only thing we haven't addressed in this case is the skin here. It looks a little swollen, and I can't really gauge from the images whether we've got true skin involvement, because if you do, then clearly that's going to be a major component of the consideration from the surgical team about what sort of reconstruction you're going to do if you're going to take some of that cheek as well.
Shah did allude to that. This will be a composite resection which will have skin excision as well.
Right. So okay. Thank you.
Perfect.
So the fibula free flap will provide bone, soft tissue, and skin all in one composite flap.
Now, coming to something which we see very common, Dr. Shah here. Arjun.
So this is a 45-year-old gentleman who came to our clinic with a complaint of restrictive mouth opening. Surprisingly, when he removed his mask, we saw a large fungating lesion which was present on the left cheek. On palpation, this fungating mass was just short of the zygomatic arch, and it was extending to the corner of the mouth. The left level 1B lymph node was also palpable, and the lesion intraorally could not be seen quite clearly.
So, Srini, this is a common lesion. Patient is having submucous fibrosis, or maybe he is having a trismus because of the involvement of the infratemporal fossa. We do not know yet. But this is a large lesion, but we could insinuate our finger between the tumor and the zygomatic process. So, how would you approach? Like, first, let us talk about the imaging, clinical algorithm that you will have for management of this patient.
So, examination, of course, now you're saying submucous fibrosis with trismus, the neck management, as well as the infratemporal extent of this tumor, if that is what you're alluding to.
Okay.
And wish there was a medical oncologist on the panel where we could have said, is there a question of neoadjuvant therapy at all? But as a surgeon, this is a frank case where you would want an MRI, and including your neck, which is very contrasted. You want to make sure that he has no other metastatic lesion, and you want to see the mandible, the skull base, or the infratemporal approach to the main extent of the tumor.
So, Dr. Shah, we did the CT scan. It's an operable stage 4A. Operable, I underline, it is a operable oral lesion where neck node is clearly resectable, the primary is resectable. Now, if we have locally advanced oral cancer like this, what is your current protocol? Should we go ahead with surgery straight away, or do we have some kind of pre-operative procedure to be done followed by surgery? What is your treatment protocol?
So I think we have been struggling with this question, Pankaj, for almost 30 years. And we have tried any number of things, preoperative treatment with PTF, preoperative treatment with platinum and cetuximab. We have employed preoperative treatment with TF. There was a randomized trial in Italy led by Lisa Licitra. And all of these trials showed that even though your response rates are up to 40 to 45%, the overall survival is not impacted. So if there is going to be consideration for giving in preoperative treatment, it is clearly with the understanding that it is not going to improve survival. Very small difference in locoregional control. So it's not even going to improve your locoregional control. It may make your surgery technically somewhat easier if the patient or if the tumor shows response to preoperative chemotherapy. You can use the word induction chemotherapy, or a very popular terminology in India called NACT. For a while I did not understand what is NACT, but everybody was talking NACT. I said, what is NACT? So, which is neoadjuvant chemotherapy. But all of this preoperative treatments, if you are going to employ that, it is with the understanding that it will incur cost. It may or may not produce response. It will not reduce the extent of surgery.
Yeah.
It may make the surgery technically somewhat easier without compromising on the extent of resection.
Perfect. So Srinivas, one thing is very clear that if we have an operable oral cancer and it is locally advanced, surgery is the first choice, regardless of whatever we may say. So looking at this lesion, Srinivas, if it is an operable lesion, what would be your reconstruction plan that you would follow?
I agree with you, Pankaj. There's nothing called non-operable oral cancer as such, other than skull base. So this would be a through and through, a complete cheek excision. I want to see how much of the mandible is affected, as we talked about. I want to see how much of his facial nerve function is affected, because I'm sure I will compromise most of his pterygomesenteric area as well as the parotid extension on this region.
Correct.
So
it will be a microvascular reconstruction.
It would be, if it is a microvascular reconstruction, if the mandible is not involved, a anterolateral thigh flap would be the best one for this one.
Perfect.
And
so a lot of time we do have these bipedal pectoralis major myocutaneous flap because of the resource constraints. But I completely agree with you that the best quality of life can be achieved only by microvascular reconstruction. Sandro, would you like to make a comment on this case? What would be your treatment protocol?
Yeah, I'd love to. So I think the treatment options that are listed here, 1, 2, 3, at the moment, I think all three of them are all reasonable options once we've had an opportunity to look at the imaging. The patient, looking from the photo, he's 45, he looks quite well. So he obviously looks fit for any intensive therapy. We would aim to operate on this patient and then post-operative therapy rather than induction. However, if this patient if this tumor was rapidly growing, what we would do is give him some induction chemotherapy as a temporizer to ensure that while he's waiting to have his surgery, he doesn't become inoperable. But if it's a slow growing tumor and we've got time, then we would simply proceed to a surgical resection. So induction would be in a setting of where we've got a rapidly growing tumor where we are concerned he will become inoperable.
Perfect. So I think we all agree that the surgery is the best treatment option for them, and microvascular reconstruction is the best way to reconstruct, and also very likely that these patients will require a combination of chemotherapy and radiotherapy looking at the lesion. And this is what Dr. Shah was talking about. There are two randomized control trials, And both the randomized controlled trials do not show that there is any benefit of giving neoadjuvant chemotherapy in case you are dealing with operable oral cancer. And whatever little benefit is there of organ preservation, it is not proven. So we move to the next case, and that is by Dr. Rahul. Rahul, are you there?
Pankaj, may I make a comment before you leave the case?
Yeah.
There is one other indication to put the patient on some type of preoperative treatment is if you are going to encounter a significant delay in scheduling surgery. If your waiting list is such that the patient has to wait 2 months, then I would put the patient on some type of induction chemotherapy, basically to put brakes on the growth of the tumor.
Correct. So that is what my residents say, that we have a waiting list of 3 weeks. Why don't we give chemotherapy to him? I said that he will come back to us to our waiting list once again after 3 weeks.
And just to add to that point, but your margins will not change even after the, that's an emphasis on that.
Correct. So let us move to Rahul's case. Rahul, are you there?
Yes.
Perfect. Go ahead, Rahul.
So we had a lady, 41-year-old lady, a teacher by profession. She came with a 2 by 2 centimeter swelling, progressive for 1 year. And it was a painless swelling in front of her ear. Can we have the next slide, please?
Yeah, please.
So no earlobe elevation was seen, and the CECT confirmed that it was around a 2.5 by 2.5 centimeter lesion, and solitary lesion on the right parotid gland involving the gland. Other salivary glands were normal. There were no obviously enlarged lymph nodes, and the radiological diagnosis was pleomorphic adenoma or a mixed parotid tumor.
Just a minute. So, Dr. Shah, would you do a CT scan or an MRI?
I think, it's a matter of choice.
Okay.
The CT scan, if your clinical suspicion is that of malignancy, you may need both the scans because you want to assess perineural invasion, which a CT will not be able to do very well, and the MRI would be better. Similarly, the parapharyngeal space extension would be better defined by an MRI, and conversely, CT would give you better assessment of the neck nodes. If you are going to do a single test and there is cost constraints, then I would do a contrast enhanced CT scan and just live with it.
Perfect. Srinivas, what would you do?
I mean, just to add to those 2 points, you could even start with an ultrasound. I mean, that's what I do in a follow-up of even a pleomorphic adenoma. If you're serially following, an ultrasound would be enough. But MRI or a CT scan doesn't matter. And if you're suspecting something like a skin malignancy, then you want to even go ahead, even get a PET scan if you think that would take care of any of this novel skin cancers. But MRI or CT scan contrasted would be ideal.
Sandro, now the people are getting a little confused. Can you summarize what would you do? Because we have CT scan, we have sonography, we have MRI, and Srinivas also talked about the CT scan.
Yeah.
Sandro, please say what.
Please, I think the patient needs a contrast-enhanced CT and an MRI if you're suspecting perineural. So if the patient's presented with some sort of facial palsy. In my region, pleomorphic is the most common cause for a benign malignancy, but metastatic cutaneous SCC to the parotid is the most common malignancy to the parotid. And many of these, surprisingly, actually have some form of perineural symptoms, so they will get an MRI.
Perfect. Rahul, go ahead.
Can we have the next slide, please?
Yeah.
An FNAC was done, and that gave a differential diagnosis of a low-grade mucoepidermoid tumor, but it was a low-grade neoplasm for sure. And pleomorphic adenoma could be a remote possibility. And the pathologist advised excision. for a detailed examination.
So Srinivas, this is a lot of the dental students, they ask this question because it is still there in the textbook. When to do FNAC and how to do FNAC, and is FNAC is detrimental in salivary gland tumors? Because all of them read the old textbook and they come up with this question.
So this is a controversy, Pankaj, which has been visited and revisited again. If you read the couple of months ago, the American Academy of Otolaryngology and Head and Neck Lesion, I think it was the Stanford group from UCI. UCI was talking about cystic parotid lesions. You certainly would want to do an FNA. So as Sandro said, if the patient came with a facial palsy, it is a malignancy, I mean, majority of the time. And you would not want to do an FNAC in those cases. So the sensitivity and the specificity is what we need to worry about. To simplify matters further, you can say if it is an infected or a neoplastic lesion, and you cannot hang your hat on what type of neoplastic lesion if they have confusion about a pleomorphic adenoma. That is the one-line answer I would tell the students.
So basically you are saying that it helps you define whether you are dealing with a malignancy. In the malignancy, perhaps you will be able to know whether benign or malignant, but at least you will be able to rule out the infections.
Yep.
Correct?
Pankaj, one line you should add is that needle biopsy can prove malignancy, but it does not rule out malignancy.
Malignancy. That was the essence of it.
If you have clinical suspicion of a malignant tumor, and if the needle biopsy is negative, I would ignore the needle biopsy report.
Perfect. Dr. Shah, a lot of papers are there, and there are old papers basically that the needle track, it leads to higher recurrence and we should avoid the needle biopsy.
I think it is a more of a myth rather than reality. Nobody does core biopsies with Wim Silverman needle now. These are fine needle aspiration biopsies. And if you are concerned about that, put your needle biopsy puncture along the course of your planned surgical incision so that you can excise the puncture site, if you will, if you are worried about it.
Perfect. And your fear is very right. This is a final histopathology report, what Rahul has mentioned, that it's a low-grade neoplasm. Pleomorphic adenoma is a remote possibility. Excision and detailed histopathological examination is necessary. That means the ball is back in the court of surgeon. So, Dr. Shah, when such a situation is there, where the pathologist has confused the patient as well as the surgeon, how do you counsel the patient about the extent of surgery and the need for surgery?
So I think when your concern is about even a remote possibility of a malignant tumor, you should counsel the patient about the risk to the facial nerve, the potential need to sacrifice the facial nerve deliberately, and its sequela, its rehabilitation, etc. Remember, facial nerve, which is functioning preoperatively, and if it is not involved directly by cancer, does not need to be sacrificed. Just because it is next to the cancer does not mandate sacrifice of a functioning facial nerve.
Perfect. So Rahul, go ahead. I'm changing the slide.
Thank you. So the surgical plan, considering it was a low grade, was to do a superficial parotidectomy, and along with the frozen section for margin analysis, a facial nerve injury consent was taken. And to our surprise, the tumor was located deep to the terminal branches of the facial nerve.
Okay. So, Dr. Shah, here is a question to you and Srinivas. If you find tumor deep to the terminal branches of the facial nerve, you might end up converting a low-grade neoplasm or a pleomorphic adenoma into a total parotidectomy. Am I right?
Yeah, I think because if you have already mobilized the superficial lobe to the extent that it is no longer viable, then it would be a total paroxydectomy. Remember, there is no operation called total paroxydectomy. Regardless of what you do, there will always be residual salivary tissue in the deep parotid space. So it is always a subtotal paroxydectomy. When you go to excise the deep lobe tumor, you are basically doing a wide local excision of the tumor from the deep lobe space.
So is there any surgical technique? Because if you go to the literature, a lot of these funny things are happening. People say that you can do just the deep lobectomy. You need not come to the superficial lobe, all those fancy things. Have you ever tried this, Srinivas?
Yes, we do it actually routinely. If it is a radiologically a deep lobe, well-defined benign mixed tumor, we do not routinely do superficial paroxydectomy. We would elevate the lower half of the parotid gland, identify the main trunk and lower division of the facial nerve, and then work under the nerve into the deep parotid space and take the tumor out, put the superficial lobe back, and come out. That reduces the indentation in the parotid space, and it does not compromise with the operation.
And I'm sure you would be selecting only favorable histology as well. But in
benign tumors only.
Absolutely, absolutely. Yeah. And also in this situation, since it is below the terminal branches, it is very difficult to dig below the deep lobe and take that out.
Correct.
So you can modify your incision, divest the digastric and approach it. Of course, if you know that it is like a neural schwannoma or something on the deep lobe, your approach is a little different going only to the deep lobe, if that is the answer you was wanting, Pankaj.
Is Dr. Shah, we have discussed ad nauseum about frozen section, because here Rahul perhaps is worried whether to sacrifice the nerve or not. And if there is some tissue which is covering the nerve and it is looking very unhealthy, then how do you decide?
Go back to the previous slide.
Yeah.
Okay, so if you see here, the nerve is like a rubber band on a ball. I'm showing you with my finger.
Yeah.
You can peel the nerve off and take the tumor out from underneath.
Perfect.
This nerve does not need to be sacrificed.
Perfect.
Conversely, if your nerve is like this in the tumor,
yeah,
then you cannot spare the nerve. And that nerve may have to be sacrificed.
Perfect.
But a nerve that is on the periphery of the tumor, and if it can be peeled off the tumor, should be peeled off the tumor if it is functioning.
Perfect.
One more point about doing a biopsy of the nerve. People have said if the nerve is too close to the tumor, but if it is functioning, should we do a biopsy? I don't think you need to do a nerve biopsy, but you will have gross indication. A nerve that is infiltrated by tumor will not be white, shiny, pearly nerve. It will be a dull, opaque, and somewhat red-looking inflamed nerve.
Perfect. So, Sandro, this patient underwent beautiful surgery. Rahul did a wonderful surgery. The nerve is preserved, and now he has a tumor, and the histopathology report, where I'm not talking about this case, but if the margins are showing changes of intermediate grade or low grade or high grade, how does the margin of excision of a salivary gland tumor dictate adjuvant treatment?
So for low grade, it has a lesser impact if it's a close margin but clear. For intermediate and high grade, clearly a close margin warrants adjuvant radiotherapy. So let me give you an example. If this was an acinic cell carcinoma and the margin was 2 millimeters, but the patient had a mass in the parotid for 10 years, then I would not offer that patient adjuvant radiotherapy, because I think the likelihood that this patient is going to run into problems from that tumor is unlikely or remote. But if you've got a high-grade mucoepidermoid that has either a 1 millimeter margin, then I would talk to the patient about offering them adjuvant radiotherapy.
Perfect. Perfect. So this is the last case. Dr. Shah and Sandro, Yogesh will be presenting this case.
Am I audible?
Yes.
Good evening, sir. Good evening. So my case is a 51-year-old male who presented to us with an ulcer over the left lateral border of tongue, 5 months duration, which was painful. He didn't have any other complaints, no neck swelling. He is a known hypertensive and controlled on medications. His performance status is 90. On examination, we found ulcero-infiltrative growth over the left lateral border tongue, about 4 by 3 centimeter, and it was about 3.5 centimeter from the tip and 1.5 centimeter from the base of tonsillingual sulcus. Tonsillingual sulcus was free, base of tongue was free, and we could palpate induration crossing the midline. There were no clinically palpable lymph nodes. So we did an MRI for him, and it was suggestive of a T2-weighted heterointense lesion, about 4.8 by 2.9 by 2.8 centimeter, and it was involving the intrinsic and the extrinsic muscles, and also it was extending into the sublingual space, and there was an enlarged enhancing lymph node about 1.4 by 1.2 centimeter at level 2. CT chest was clear.
Going back, Dr. Shah and Srinivas, whenever we have lesions like this, which is very painful, we are not able to examine it entirely. Do you have the practice of examination under anesthesia, or you will just do the OPD examination?
I think examination under anesthesia generally would be indicated, not for oral cancers, but oropharynx, hypopharynx, larynx. Most oral cavity cancer, unless the patient has trismus and you can't get your finger into the mouth. But if you're able to palpate the lesion through the oral cavity, you rarely need EUA because it will spare an additional anesthetic procedure.
Perfect. Completely agree. And here is the MRI picture. So Sandro, this patient has gone to you. With this MRI picture and the clinical history, what would be your approach?
Yeah, so this is one that would often create a fair amount of discussion in the clinic. And to be honest, at the end of the day, it's going to come down to what the patient is prepared to accept in terms of morbidity. Looking at this, a fair amount of tongue would need to be resected, and there's the functional deficit that would go with that. It's likely the patient will need long-term PEG feeding. And so in this particular case, we would have a more robust discussion about offering this patient definitive chemoradiotherapy because of the functional deficit that may result from the surgery.
Dr. Shah, what would you do?
I think, Sandro has hit it right on the nail. You don't need have to worry about only tumor factors here. You need to know the patient's general medical condition to withstand a big operation, patient's profession, patient's own desires. Remember, the curability of this tumor is in the 20% range, and therefore quality of life becomes an important issue. And patient's input is more important as is the importance of the operating surgeon or the radiation oncologist. Okay. And if the patient says, I would rather remain functioning and live for 2 years than be not able to communicate, be PEG dependent and trach dependent for 4 years, I would rather take the 2 years. And I think we have to respect that.
Perfect. Srinivas, what would you be doing?
I would agree with the alumnus here. If I'm forced to operate as a surgeon, the key thing to look for is, again, quality of life assured, and then the posterior extent. And if you have to do surgery, that it's a multimodality treatment given, but if you have to do surgery for this patient as a salvage setting or a preoperative setting, you want to make sure that your pedicle on the other side is intact. If you lose that pedicle on one side, you may lose sensation, you may lose things. So it would be almost a subtotal glossectomy. including the floor of the mouth with a huge ALT reconstruction with bilateral neck dissection. But as a surgeon, I'm thinking about, again, quality of life of swallow, but you want to preserve the pedicle on one side.
Perfect. So Yogesh, what did you do?
So we exactly did the same thing. We were able to save right-sided lingual pedicle, and we did near total glossectomy. We put it in ALT flap, did a bilateral neck dissection, and this is our final histopath. So shall I? It was a moderately differentiated squamous cell carcinoma, tumor size 5.2 by 4.5 by 2.8. Depth of invasion was 3 centimeter, and there was PNI present in small nerves with lymphocytic host response pattern 2, worst pattern of invasion pattern 5, and all mucosal and soft tissue margins were free of tumor. And there were 8 total positive nodes, 7 on the left and 1 on the right, with the level 3 node on the left showed ENE positive.
Okay. So, Sandro, we certainly know that this patient would require concurrent chemoradiotherapy. Am I right?
Correct.
Okay. Now, since we have decided that certainly this patient requires concurrent chemoradiotherapy, I want to draw your attention and I want your inputs on 4 things. What is this role of worst pattern of invasion that increasingly we are studying and our pathologists are reporting?
Sorry, Pankaj, repeat the question.
The worst pattern of invasion is pathologists are reporting. So do you give importance to the pattern of invasion these days with regards to adjuvant treatment?
Pankaj,
not so much.
Can you decipher for me what is LHR and WPOI?
This is a problem when sometimes you use the abbreviation. So, Yogesh.
Yes, sir.
So LHR pattern, even I do not know. What is that?
So
heterogeneity,
lymphocytic host response.
Okay. I'm sorry.
Yeah.
So, Dr. Shah, we were discussing, we and Sandro, about the pattern of invasion. What is the relevance?
Yeah, so I think, it is important, and it is one of the histopathological adverse features if you have invasive islands in contrast to a pushing frontier. Because invasive islands implies that the tumor has extended beyond the visible or radiologically demonstrable margins of tumor. And even though your processing of the specimen may show negative margins, there is a higher probability that there is residual tumor microscopically in the surgical bed in spite of negative margins.
Perfect. So Sandro, in your clinical practice, do you look at, are you reporting patterns of invasion and do you give importance to this?
We do report on the pattern of invasion. We do look for sort of those islands of malignant cells that are separate to the main tumor mass, and that certainly worries me as a radiation oncologist. It does mean that I have to broaden the high dose of radiotherapy, and certainly in this case, there's no doubt he will receive bilateral irradiation. But if you were to do say a hemiglossectomy, ipsilateral neck dissection, and in the pathology we saw islands of malignant cells away from the main tumor mass, then that would encourage me to include the contralateral neck for sure.
Perfect. And Dr. Shah, one question is that, what about the contralateral neck dissection?
So I think, contralateral neck dissection in lesions which cross the midline is often talked about if the neck is radiologically negative, clinically negative, radiologically negative, and if there is no large volume disease in the ipsilateral neck, I would hold off on the contralateral neck.
Perfect.
Conversely, if the primary tumor extends on both sides of the midline as this tongue lesion did, if you had bulky nodal disease on the ipsilateral neck, then I would go to do at least levels 1, 2, and 3 in the contralateral neck.
Perfect. So I think we have finished our time. We are already 6 minutes behind the time. and Dr. Shah does not like exceeding the time limit. And Sandro, you made an error of using the word hemiglossectomy. Dr. Shah does not like that word. I'm just kidding.
Because cancer doesn't know what is midline and what is the difference between anterior and posterior third of the tongue.
Okay, I shouldn't interfere with surgical terminology. But I know we're over time, but there was one important point Pankaj and Jatin Shah made. Did I hear correctly that in this particular case, you would not have done an EUA?
So basically what Dr. Shah said that if fingers can be put inside without causing discomfort to the patient, you would prefer a OPD examination. However, he did say that if there's a base tongue invasion, oropharyngeal invasion, and it is not possible, we might. But what is your view, Sandro? That's Dr. Shah.
I didn't hear that
Sandro,
caveat.
I'll answer your question. If I can chip in, what I would do is just for medical legal case or even in the OPD, when I use my lidocaine or oxymetazoline spray, I put it on the tongue. I use a flexible endoscope to just see the other side through the nose. A flexible nasal endoscopy in the clinic without putting the patient, you can still assess most of it.
So Sandro, would you like to prefer endoscopic examination under anesthesia?
I guess the point I was going to get to was that a big bearing on the functional outcome for this patient would be whether there was tongue-based involvement. The informed discussion would require good knowledge from the clinicians involved, whether there was true tongue-based involvement, because the discussion would be a little different than if it was just purely the oral tongue or floor of mouth or oral cavity.
Correct. So here I think we would heavily rely on the radiological examination because there can still be a submucosal extension which may not be evident on clinical examination. Dr. Shah, I would like to make a final
let me just close this point. You always examine the patient in the operating room before you take your scalpel in the hand. What we are talking about is examination under anesthesia as a separate procedure before taking the patient to the operating room for surgery. But when the patient is in the operating room for surgery, you invariably always, and you must palpate the lesion on the day or at the time of surgery before you start the operation.
And you can have a preoperative swallow assessment too, just a speech and swallow assessment, so that the patient has a pre-resection guideline of how they can do after.
So I take the privilege of again saying that it was a pleasure talking to all of you, and thank you very much for all your insightful inputs. And I would like to thank Pramod, Amit, and Preetham for this wonderful session, and all the audience. At max, we went to 300 audience. Thank you for participation.
Thank you very much.
Thank you.
So Pankaj sir, we would like to have a second part also from sir whenever he gives a date, because some cases are left.
So they need another date from you. We will talk about it on the email.
Yes, sir.
Perfect. Thank you. Okay.
Good night. Thank you.
Good night.
Thank you.
Good night.
Thank you very
much. Much everybody. We have 500 people following us even now.
Wow. Thank you so much. Okay.
Pankaj sir, there is a debriefing session. If you can join us, we will post the link just for 10 minutes.
Yeah.
All right. That's for all the hosts and co-hosts.
Perfect.
Preetham?
The only problem is my bladder is going to burst now. I drank a lot of
you can join, so you can join and